try and keep to time. So welcome to ASPE Belfast 2019 Day 2, or some of us Day 3. We're here for pre-conference. My name's Colette Chapman. I'm chairing this session. I just have a couple of housekeeping announcements to make. We're gonna wait a couple of minutes. So my career background is as a ventriloquist, and I can throw my voice quite deep. No. Oh, sort of dance, don't. I have got a dodgy knee and I am from Norfolk. That's all I'm going to say. Did my best to have a bit of exercise. Okay, so a couple of housekeeping announcements for people that are here in the room. Obviously, welcome any day delegates to conference. There are people in orange t-shirts who will guide you, or actually probably anybody who's got an ASPE badge on. We're familiar with the venue now. In terms of after this keynote and the AGM for ASPE, we have session 28 and session 30. They have been put on the app, that they are cancelled. So just to remind you, session 28, which is room 2A, and session 30, room 3A, both workshops unfortunately are cancelled. So it does mean there's plenty of other workshops you can go into. So perhaps during the AGM you'll select which ones you want to go to. There's also a MAD SIG, which is Managers, Administrators and Directors Special Interest Group at 2 p.m. That's going to be a short 15-minute meeting in the boardroom, which is on level 2. Thank you, couldn't quite remember. So anyone that's interested in that special interest group or a part of that special interest group, just a brief meeting to think about us coming together next July. And Michael Penny organises or leads organising the SIG. Thank you very much. So it's my great privilege to introduce our keynote speaker this morning, Epic by name, Epic by nature. Walter, I'm sure many of you have read one or two, or if not many, of the papers that he's published over the years. Significant support. We've gained significant support in our SIN Centre from papers that Walter's either led or co-published on debriefing, thinking about the notion of reflexivity and team working. He has co-authors a website, which Debrief to Learn. I'd love to signpost you to that. Great podcasts and resources on there that I've used. Walter's also done a workshop here this week, in fact, on qualitative research. So he's extremely well read, well written, and he's an extremely lovely gentleman. That's what I want to say. He said I could say something personal, but I'm keeping it short. I met Walter in CSAM Paris socially, thinking, oh my gosh, I'm sitting next to Walter Eppich. And what I found was he's just a really lovely, quirky gentleman. He's very interested in my accent and very interested in my laugh. But what he doesn't know is I also find his accent quirky and his laugh a little bit interesting. And all I'll tell you about is if you ever get a chance to have a social time with Walter, he does like a little dirty martini, and he does like a little bit of gossip. So I'm going to invite Walter. He's not going to come up on the stage. He wants to talk in the front. So I'm going to invite Walter to lead his keynote, and we'll have hopefully an opportunity to answer some questions later. I'll sit over there so I can keep an eye on everything. Is that all right, Walter? Welcome.
Thank you so much, Colette, for that very kind introduction. And I have to say, I also have great admiration for you in that, I don't know who was at the party yesterday, but when the music started, which very much reminded me of the United States, to be quite honest with you, Colette was the very first person on the dance floor. And that I always find quite admirable too, because I hate to be on the dance floor by myself. So thank you so much for coming. I know it's often challenging to get up on the morning after the conference party, and so I appreciate that so many of you have come today. And what I'd like to do with you over the next 40 minutes or so is to give you a little bit of insights I learned across my journey over the past few years, doing some academic work, and of course the work in doing debriefing, teaching, and clinical supervision myself. And I'm going to tie these strands together for you. The title of my talk is Learning Through Talk, Exploring Synergies Between Simulation and Workplace Learning. And I'm going to unpack these notions for you. If you're interested, in the right lower hand corner is a QRS code, which is going to give you a link to a PDF of the main slides. I will say, because I was having internet issues this morning, it's from a talk that I gave several weeks ago. The slides are pretty much the same. So if you're interested in getting the key references, please aim your camera up there, and that's a QRS to the main slides. And I'll give you a second to do that. Yeah, you could also just take a picture and then have the code be on your computer and then download it at a later time. All right. Thank you so much. So how did I become interested in talk as a notion, which I'll define for you in a moment. Now, I will say I'm a pediatric emergency medicine physician by training and in practice. I still have active clinical practice. And I'm not only was interested in debriefing in my work in simulation, but I became very intrigued by the amount of time my resident physicians spent on the telephone. And I became intrigued by how they learn to communicate in this medium and also in the larger medium of clinical practice. Medical students show up, they don't know what to say or how to say it, and then they graduate from residency and they're quite expert in this aspect of their work. So what I'd like to do now is explore some main questions, the first of which is, what is talk? Why does it matter for clinical education? And how do simulation and workplace talk inform each other? So what is talk? Talk is nothing more than joint social activity that's comprised by its verbal, nonverbal content as well as its social implications, which sounds like a pretty straightforward thing. Talk is one of those things that's so mundane we take it for granted. A lot of the medical education literature, the health professions education literature, talks about learning by doing, when in actuality it is learning by talking. So much of the work of clinical practice is spent talking with patients, talking with other health professionals. And we can actually look at talk as a large portion of the work that we're doing, which very logically has led to a whole host of professional bodies, certainly in my country, such as the Accreditation Council of Graduate Medical Education, making specific competencies related to talk. Milestones, entrustable professional activities. This focus on talk as work has led to a discourse around talk as a communicative competency. You need to be able to talk in certain ways, which makes very good sense. However, it has detracted attention away from another very important function of talk, which is talk is a social medium of learning. And for those of you who have children, you'll notice this as well. There's a lovely paper by Anna Safard who really looks at the two scholarly perspectives of learning, one of which is learning as acquisition and learning as participation. And if you take a very participatory stance on learning, then the role of interaction and conversation will become obvious. As I wrote in a book chapter with some of my colleagues, if you think about it in this way, talk not only mediates learning, but also the patient care and team-based settings, which seems like a basic notion. Now, if you look at this, though, it makes very good sense. When the communication breaks down, which it often does, patient care suffers. And what I'm going to argue today is that when communication breaks down, not only does patient care break down, but learning breaks down. The good news is that we can steer the talk of practice, though. We can structure how we interact with each other that can promote both learning and patient care. There's lovely literature on interdisciplinary ward rounds. We can actually structure ward rounds to bring people together in time and space and give everyone a role, nurses, medical students, SHOs, registrars, residents, and actually reduce preventable adverse events. or the use of checklists is another example. For those of you who may work in operative specialties, you know that the WHO has a checklist, and that can improve patient safety, but that also brings people together. Handoffs is another great example. Amy Starmer, who's a pediatrician from Boston, did some lovely studies looking at a structured handoff process, and actually showed in a paper that was in the New England Journal of Medicine several years ago that you could reduce preventable adverse events if you structured how handoffs happen. And this was within the setting of resident physicians. And then, of course, there's simulation, which is why we're here today. We spend a lot of our effort in simulation helping people learn how to communicate, but actually in that learning how to communicate, they're learning more than we think. So why does talk matter? Talk matters because it influences how we design curricula, how we develop faculty, and how we support learners. So what I'm going to do for you now is explore how talk contributes to clinical education. And we'll look at talk in two specific instances. The first, which is learning through talk for practice, that is in educational settings that prepare people for their clinical work, and learning through talk from practice, which is the learning that happens in the workplace when people are actually caring for patients. And learning is a byproduct of that clinical work. So learning through talk for practice and from practice, and I'm going to look at specific instances. The first instance is healthcare debriefing, which is something well known to you because you're simulationists. And then I'll look at telephone talk, which I referenced earlier, and I'll look at team reflection and its potential to promote learning. And I'll tie all these strands together by looking at the synergies between these two spaces. So first, healthcare debriefing. So what are debriefings? As you all know, debriefings are nothing more than conversations. Conversations to help people make sense of events, explore what was working, identify areas for improvement, with the aim of improving future performance. Now, I will say very often people look at debriefings as being also therapeutic in nature. And I will say I very much in my work focus on debriefings as an educational event, not as a therapeutic event. So when someone approaches me and say, you know, there was just a serious death on the ward, a patient that was beloved by all the critical care nurses and physicians has died, could you come and do a debriefing? I will say, thank you for the invitation. I think there are other people who are better able to support that. That's not me. Chaplains, social workers, and the like, people who have training in that regard. So I'm very much focused on educational conversations. In the literature, it became clear to me several years ago that we were very much focused on the process of debriefing, or how to debrief. And everyone has their own debriefing model. There's debriefing with good judgment. There's other models of debriefing. And they all seem to be very decontextualized and didn't as much talk about the content of the debriefing or what to debrief. And as we know, what we're looking for is this sweet spot between process and content that very much depends on the context. Who are you debriefing? What is the learning goals? Who are the learners? How much time do you have? Because one size does not fit all, and this is something that Christian Crow wrote about in a paper where he discussed the artistry of debriefing, where expert debriefers actually make these in-the-moment decisions and exhibit what Adam Cheng and I and others in a recent paper about debriefing development wrote about as adaptive expertise. So Adam Cheng and I, who's a very dear colleague, we looked at the literature and focused on post-event debriefing, so those debriefings that happen after a simulation event. And in our review of the literature, we identified that there are specific educational strategies that people use, and we decided to blend them in the analysis phase of a debriefing. So the Pearls model of debriefing is not a completely brand new model, but what we articulate in the paper is that you can blend various approaches in the same debriefing, depending on how much time you have, who your learners are, what the performance domain is. Is it teamwork? Is it communication skills? Is it technical skills? So the educational strategies were to get learners to self-assess their own performance, to lead a focused discussion around specific topics, and then to provide them with information in the form of directive feedback or teaching. And I think this is something you all recognize that you're already doing in debriefings, and we provide some guidance as to how you might think about that. The big thing is adapting the debriefing to the context. So I will say one size simply does not fit all when we think about debriefing. In the next piece of work, also with Adam and others, we looked at how we might structure feedback and debriefing to achieve mastery learning goals. Mastery learning being an educational design model where you work to get everyone to a specific mastery standard. What varies is not who achieves it, but how long it takes for people to get there. And what we did, though, is we focused on within-event debriefings. We focused on the types of debriefing conversations you might have when you pause the event, so pause and discuss, or whatever you might call it in your own center. And specifically, we focused on resuscitation training. And we looked at 2 studies that had previously been published where people showed that they used this strategy of debriefing for brief moments during the event, pausing, let's discuss this, try it again. Let's rewind, let's pick it up from 30 seconds ago. And in these studies, they had amazing educational outcomes. And what we did in this paper is we integrated Betsy Hunt, who was one of the authors on one of the papers, and Vibhajo Sadal, who was the educator on the other paper, to say, what exactly were you doing? Because in each of these papers, what they would do is they would say, debriefing occurred in a structured environment, in supportive setting. The sessions lasted 2 hours, and there were 4 of them. So you're not able to replicate what they were doing. And what we found is that in many ways, these micro debriefings, as we call them, during advanced life support are incredibly powerful. And they're highly contextualized. And I would argue for you, if you're really doing resuscitation and advanced life support training, doing a scenario for 8 or 10 minutes and then spending 20 or 30 minutes debriefing, there is simply no evidence for it. There is simply no evidence for it. Now, if you're doing, because it's very algorithmic based, right? There's a steps that people should adhere to. When things are vague and uncertain, certainly that may not apply. But I would encourage you to have a look at this and look at the other primary studies by Diane Wayne, who's one of my colleagues at Northwestern, the work by Betsy Hunt, who talks about rapid cycle deliberate practice, and see how you might tweak your practice in that way. This work fed into the consensus statement from the American Heart Association, which Adam Cheng led up. I was the lead for the feedback and debriefing working group. And what we articulate in this paper, which really has great impact for how we train people to do advanced life support, at least in North America, that it's really important to think about the timing of the feedback and debriefing, the process and content, and importantly, to integrate performance data. And I know that people here at Laerdal, by the way, no commercial interests, are very interested in gathering performance data in real time during resuscitation events, quality of basic life support, compression depth, etc., interruptions and compressions, and feed those back to learners so that they can improve. So rather than debriefing after an advanced life support scenario for 20 minutes, maybe you need to look very focused. Why did people pause the compressions for 30 seconds before the shock in a case of ventricular fibrillation? So I've spent some time talking about learning through talk for practice, i.e. in debriefings that were happening post-event, during simulation events and pauses, and how that thinking fed into resuscitation education science. And I'm going to look at learning through talk in the workplace, specifically through telephone talk and through team reflection. And what I would love for you to do is think for a moment with your neighbor about what it was like for you to learn to talk on the telephone with other health professionals, talking to other physicians, talking as a nurse to another nurse, giving handover. What is it like for you as a more senior person getting telephone calls and listening to people chat with you? Just talk for 2 minutes amongst yourselves about that experience. So I would invite you to published earlier this year. We wrote about how young doctors learn the lingo while talking on the telephone. So I was very interested in how young doctors learned not only to talk, but from talk on the telephone. And so what did we do? By the way, many of you will recognize that as opposed to what our non-medical relatives think, who think we spend our time seeing patients, talking with them, doing life-saving interventions like they do on television. A lot of the work that we do is spent talking on the telephone. So I work in an emergency department, so my residents, my SHOs go into the room, see patients, come out, we discuss, and then they spend lots of time on the telephone, getting the patients admitted to the hospital, calling other subspecialists, calling the primary care provider to ensure follow-up. There's a lot of time spent on the telephone. And yet a lot of the work that had been done very much focused on these telephone conversations is something about information exchange. Are you conveying all the information that needs to be conveyed? I was personally very interested in the learning potential of these conversations. It's such a substantive part of what people are doing at work. What are people learning? So what did I do? I asked, how do work-related telephone conversations contribute to clinical education? And work-related telephone talk for me was speaking with another clinician or health professional, not with patients. That's an important thing too. That wasn't the focus of my work. So what do we do? I did 17 in-depth semi-structured interviews with physicians in training from level 1 to level 8 from a variety of specialties, including pediatrics, emergency medicine, orthopedics, surgery, internal medicine. I used a methodology or an approach known as constructivist grounded theory, and I used a sociocultural lens. Now, of course, the question I often get is, why did I not use analyzed telephone conversations? That would be an approach. The reason I didn't is because I was interested in what people thought about these conversations, what were their motivations and perceptions behind them. So what did we find? We found that there were positive influences on their learning, which is not really a surprise. The thing that's surprising is what helped them learn. In our analysis, we identified productive conversational tensions. Tensions that come up that actually are a little bit uncomfortable. A number of people in prior work have written about tensions as being something negative that we want to avoid. And yet these productive tensions that we identified are things that are related to dealing with power differentials, dealing with pushback from people who say no without due concern or consideration of what your issues are. And then how do people deal with uncertainty? The question is, why do these productive tensions lead to learning? Well, because they're a little bit unpleasant, people want to avoid them. And because they want to avoid them, they change how they talk in the future to avoid future tensions. So let me give you some examples of quotes. So when you think about power differentials, you don't want to call your attending up in the middle of the night and then clearly not have thought about what's going on with a case. It's just disrespectful. And there's the self-respect aspect of it. I don't want them to think I'm an idiot. So lots of people talked about it being very intimidating speaking with the attending or the consultant who's on call overnight, or their supervising physicians. So when we think about dealing with pushback, in medicine, most of the time when there's a difference of opinion, it's kind of subjective. You pick and choose those battles. You're storing up your ability to push your opinion harder when it really matters. Dealing with uncertainty. This is from a very early career resident. You get a lot of pages from nurses about little things. And sometimes you're not sure. I often feel like I have to check with my senior. Sometimes I do know the answer, and that's great, but sometimes I do have to say, I don't know. I'll have to call you back. By the way, throughout my data, there was lots of examples of people being unsure and how they would express being unsure. So when you think about these telephone conversations that people are having, so in my country, we call them residents, fellows. Here you would say SHO, foundational doctor, registrar, who is talking to some other clinician. there's a patient care context that's governing these conversations in terms of why these conversations are happening and with whom they're speaking. And that people are perceiving these tensions and managing the tensions within the conversations. And how they're doing that is through what they say and how they say it. So what you say is the medical knowledge, the informational content of the conversation, as well as the social content. Managing the relationship, collegiality, being polite. Then, of course, the how you say it, which is incredibly important, which is the rhetoric of it. How are you persuasive? How do you make an argument? How can you convince someone of something? I need you to come now. What does that mean? How do you get someone to come now? So people said that the first substantive sentence is critical because people won't listen unless they know what they're listening for. They also stressed that they needed to learn the lingo in order to paint a picture to someone by using buzzwords that conveyed information and urgency concisely and persuasively. So many times, I'm sure this is something that resonates for you, people are calling you and they're talking for minutes on end and you finally realize, wow, this is important. Or you don't think it's really that significant, and then you show up to see the patient. You're like, oh my God, why didn't you describe this to me? So yes, I've described these productive conversational tensions, but I do want to say, please beware. I'm not saying we should be intentionally creating tensions, because we don't want incivility or disruptive behavior, which many of my study participants talked about. They talked about wanting to just get off the phone because people are being rude to them. We don't want to be rude. We don't want to be making tensions. We want to be civil and polite. These tensions will arise on their own. So as an extension of this, what does this mean for us as simulationists? We reanalyze the data from these interviews to perform an educational needs assessment to say, how could this inform what we do in simulation? So we used a thematic analysis, and our main findings were that clearly junior doctors need training. And there were two specific instances that played a role, which were calling for advice was a huge issue, calling subspecialists, calling supervising physicians. Whether it's a foundational doctor talking to a registrar, or maybe a registrar calling a consultant, or someone from one specialty calling another. And then also structuring these presentations in a way that was both succinct and convincing, in a way that could convey urgency. Like, I need you to come now, and this is why. So I heard from so many people that they would have to live through rambling presentations in which the severity of the patient's condition gets lost, with the result that nobody's going to pay attention. We were like, okay, great. Great. They also talked about doing other work on the computer while they're waiting for the people to get to the point. Also, that people would present irrelevant information while paradoxically leaving out critical information. So if you don't really know what is important, you're going to tell me everything, which I maybe don't care about. I care about the important things. So as a listener, you're waiting, okay, let's just get to the thing I want to hear. And more experienced people just get there right away. John, I see you're a surgeon. You know exactly what I'm talking about. Everyone talked about speaking with surgeons. So the main findings were what helps them learn, and very obviously this was not a revolutionary finding, but there were also explicit teaching and feedback practices that more senior people would use on the telephone. But most importantly, the junior doctors appreciated when they would hear the why behind people's recommendations. Not just do this or do that, but do this because this is why it's important. So sharing your train of thought. But the other thing I think that was really important is that there are all of these what we called informal conversational interruptions and questions that would happen. So let me give you an example. I'm calling John, my surgical doctor, and I'm saying, hey, John, I have this 6-year-old child here in the ED, 3 days of abdominal pain, and do 2 days. Well, that's where I'm getting to. Like, why are you calling me? And some very reflective junior doctors would say, you know, when I get interrupted 2 sentences into my presentation, by the way, getting interrupted is awful. Getting interrupted, that tells me when I calm myself down that I need to say it differently to avoid getting interrupted. And people sort of at the end of their first year, beginning of their second year would say, geez, whenever I will call this one particular surgical resident called John, he would always interrupt me, but you know what, he doesn't interrupt me anymore. I must be learning something. The other thing is all these questions that you get. So let's say you call the infectious disease doctor about a patient who has prolonged fever. Hey, I got this, Dr. Gabe, I have this patient with fever for 2 weeks, blah, 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 blah. And then Dr. Gabe says, have they traveled anywhere? Do they have any pets? Do they have this? Do they have that? The astute resident will realize that these questions, which Dr. Gabe needs solely to do his job and to give advice, are really like, you need to be telling me this the next time. So these informal conversational interruptions and questions are actually what we call disguised feedback. It's feedback that learners are getting throughout these telephone calls that can shape how they're learning and what they're doing on the telephone in other venues. So here's a quote from one of my participants. Even if they're not specifically giving you feedback, this means the supervisors or their subspecialists, you can tell if they have all the information that they want, or if you've left out some things. You get better at unpacking disguised feedback on the other end of the phone. So that led us to think then that this disguised feedback is something we could use, or I'm proposing to you that we could use, because we can help people learn how to learn through simulation. So when we think about simulation, I like to think about the traditional paradigm, which is learning how to perform. We bring people into simulation so that they learn how to do something that they can then do better in their clinical work, whether it's a procedural skill, an aspect of teamwork, decision-making. But I'd like to submit to you that we can also help people learn how to learn by preparing learners to learn from their clinical practice. So I'm going to give 2 examples to juxtapose these. In terms of clinical communication, you can teach people how to use a structured approach to calling a consult, which is the foundational doctor is calling the surgeon to get advice. There's all kinds of structures for how to do that. A structured approach to communication is also SBAR or ISBAR as an example. But I'm saying you could sensitize learners to the disguised feedback they're going to get. Listen, if you're getting interrupted, that means you need to be more concise about your one-liner at the beginning. If you're getting all these questions, what they're telling you is, I need this information up front the next time. So when you're getting these additional questions, or you're getting questions earlier in the presentation, that means you need to put this information earlier. And by the way, all of you know when you're either talking to someone in person or on the phone, and someone's presentation is just perfect. They give you the information as you want it, as your thought process are working through the issue. It's like a thing of beauty, right? So I think what we should do is integrate telephone talk into existing simulations. I think that's a powerful way of promoting learning, by sensitizing people and debriefing these interactions. I'm going to shift gears for a moment to team reflection. So this is some work that I did with a psychologist from Zurich, Switzerland, called Jan Schmutz. We called it team reflexivity because that's how it's used in the literature. We can just call it team reflection too. We came up with a conceptual framework for how people would reflect together. So if you look up here at the slide, you see this patient on the stretcher. This is representing the patient care episode. And then there's a before, during, and after. And traditionally, when we think about reflection, which we call post-action afterwards, team reflection, it's just like a debriefing, which is how I became interested in this together. It's conversational learning, and there's a whole literature on team reflexivity. I was actually blown away by the fact that I'd been writing all these papers on debriefing, but I'd never actually looked at the literature on team reflection or team reflexivity. And that's what they're doing, is they're writing about debriefing, but they don't call it debriefing. So what Jan and I did is we thought deeply about this and thought, but actually people can be using these same reflective processes beforehand. And many of you will be well aware of things like huddling and briefing in advance. So this is not a new thing. And then, of course, there's the brief moments of reflection in the moment, in the heat of the moment, such as recapping, summarizing, and importantly, inviting input from the team, with the goal of creating shared mental models, a shared understanding, getting everyone on the same page to promote adaptation and learning. We actually looked at this empirically, namely this notion of recapping, summarizing, and inviting input, which many of you will be teaching in your simulation courses. And we found, based on review of 70 simulated pediatric emergencies with pediatric teams that were interprofessional nurses and physicians of various sizes, that this in-action team reflection promotes performance, especially in larger teams. And of course, this in the action team reflection might be just, let's summarize for a quick moment. This is what I think is going on. This is what we've done. Is there something we're missing? Any other suggestions? So it doesn't have to be a big, long event. For those of you who've downloaded the references, I would just suggest that you pull this paper and have a look at how you might integrate team reflexivity or team reflection into your simulation scenarios. And I will say one quick thing. What we often do in simulation is we throw people into a simulation without any time to prepare in advance. Because, hey, that's what happens in clinical work. But in actuality, very often we do have a bit of a heads up. So Victoria Brazel, who is an amazing emergency physician from Australia, does a whole simulation program with her trauma teams that's based on only getting the teams ready to deal for the patient. She calls a trauma alert. The team convenes in ED in situ. They do a quick scenario, getting ready for a patient who's coming in with who knows what kind of history. And then the scenario ends and they debrief it before the patient even arrives. So we've studied team reflection in other settings. I went to Antarctica last year. That's me waving, by the way. It was quite fun. It was amazing to be an education researcher and go to Antarctica and do qualitative research. And we were looking at adaptation. By the way, adaptation is also learning in Antarctic research teams. We observed them. We did a rapid ethnography. We went out with them into the field. We attended their meetings. We hung out with them in their informal leisure time. And we did 23 semi-structured interviews, both the research teams and the logistics staff. You might wonder why research teams? Well, they're doing very dangerous things. They're getting samples from the bottom of the ocean or the bottom of a lake, and it's freezing cold. The water's 2 degrees, 3 degrees centigrade. People can die. They have these leopard seals, which are predatory animals. They can grab you if you're diving, and they pull you down and you drown to death. Or if you're on a glacier and you fall into a crevasse, you die if people can't extract you. So they do very high-risk things at the mercy of the weather. We were at multiple stations, and we gleaned some lessons that I think are relevant for healthcare. When we think about how people interact and work together, what supports adaptation and team working in this setting is social cohesion and relationships. Namely, building trust and knowing that people have my back. And that the preparation for the critical event happens long before the event happens. It's in the informal time, the hanging out, the meals, the social activities. When we asked them, what helps you build the trust? They said, drinking beverages. And that they would do briefing and debriefing that occurred both formally and informally. And these reflections in the moment were very important. So I'm winding down, Colette. So I've talked about learning through talk for practice and learning through talk from practice. And I've used healthcare debriefing, telephone talk as team reflection to look at this what I think is an important issue. And I think there are synergies. Number one, context is incredibly important. We need to adapt our conversations, both in educational settings and at work, to the context, which is something we know, but we need to help our learners be adaptive. Framing conversations at the outset is incredibly important. We do this in educational environments. We need to do this more in the work environment. Process and content are incredibly important in both settings. How we structure these conversations, what conversational strategies we use are important. Feedback can be both explicit and disguised. And I think it's important to tell our learners that not all feedback is coming with a neon sign attached. Relationships matter and rapport with our learners matters. That there can be productive tensions that promote learning. And I would argue perhaps there's some productive tensions in debriefing too. Maybe it doesn't all have to be happy, kumbaya every second. Simulation is an important avenue to promote learning, and I think the why is something that really binds these two arenas together. So in summary, talk is joint social activity. That's important because it's an important medium of learning and patient care, and that simulation and workplace talk inform each other. And I would leave you with this thought. Talk is more than a competency. Talk drives learning. And I'm going to point you, just want to thank my PhD team who really supported almost all of this work that I just presented to you, as well as Adam Cheng from Calgary, Canada, who's one of my dear colleagues and friends, as well as Jan Schmutz. If anyone would like to read my PhD thesis, there's a link, and the Debrief to Learn website is there as well. Thank you so much.
Thank you, Walter. Very fabulous talk, as always. I knew you would. Does anyone have a question? We have the chance. We've got